Everybody already know what this is. Step 1 prep. Here we go. A 28-year-old man presents to the clinic with complaints of persistent shortness of breath and wheezing despite using asthma medication. He has a history of mild asthma and is currently taking a daily inhaled corticosteroid along with an as-needed short beta agonist. Pulmonary function shows an FEV1 improvement of only 10% after administration, whereas typical improvement is around 35%. Genetic testing reveals a single nucleotide polymorphism on a gene encoding the Beta-Adrenergic receptor. Which of the following most likely explains this suboptimal response? All right, is it A, increased alpha-1 receptor density? So alpha-1 receptor density, alpha-1 causes bronchoconstriction, but this would not be relevant to the short-acting beta agonist. All right, what about beta-arrestin? That at least has beta in the name, right? Well, that mediates the receptor desensitization with chronic agonist use, not genetic baseline polymorphisms. So that's not the answer. How about elevated bronchial, smooth muscle, CAMP degradation? All right, so CAMP degradation is going to involve PDE overactivity fixed with the PDE inhibitor, and it's not linked to the ARB2 polymorphism I'm talking about here. And what about this guy? Polymorphism affecting the receptor signal transduction. That sounds right because they have asthma, but they're failing to albuterol because of the beta-2 adrenergic receptor polymorphism. So it impairs the receptor's ability to activate, how does this normally work? GS, and thereby stimulate CAMP production that we talked about. And so bronchodilation is thereby limited. So the other stuff like PD activity, muscarinic upregulation, that affects CAMP, but downstream, or it affects the parasympathetic tone. But the key here is the genetic receptor defect, right? This GS to CAMP pathway, so it's the receptor polymorphism that affects the receptor signal transduction. That's our correct answer. All right, how about the upregulation of muscarinic receptors in the airway? Well, that would increase the parasympathetic bronchoconstriction, but there's no genetic testing clue there, and so our answer is going to be D. The bottom line is beta-2 adrenergic receptor polymorphism impairs albuterol's efficacy, leading to suboptimal asthma control. In our next question, we have a 50-year-old woman presenting to the clinic with a sudden onset of severe lower abdominal back pain and fever for 24 hours. Her medical history is significant for long-standing type 2 diabetes and hypertension. On exam, her temperature is 101.3, blood pressure is 130/85, and a heart rate is 110 beat per minute. She exhibits guarding and rebound tenderness in the lower abdomen. Lab results show a leukocyte count of 16K with a left shift. A computed tomography scan of the abdomen reveals pneumoperitoneum and thickening of the colonic wall. Which of the following is the most likely diagnosis? Okay, so what's important about this question? Well, first of all, what in the world is a pneumoperitoneum, right? Pneumo, air, peritoneum, you know what that is. So it's basically the medical term for the presence of free air in the abdominal cavity or peritoneal cavity outside of the digestive organs. And this could be super serious. It could signal the perforation of a hollow viscus like the stomach or the intestines, and that would need urgent, sometimes surgical intervention. But it can also be spontaneous, like mechanical ventilation. And you can see this in X-ray. Also, by the way, you can go through your whole entire medical school career and never be explicitly told what viscera is, right? Those are the internal organs in the main cavities of the body. And this is one of my gripes with medical school generally, is they don't teach you things. They just assume that you should know those things. So viscera is literally the internal organs in the main cavities of the body, like the abdomen or the intestines. And so viscous perforation is the most common and serious case where you get a hole in the gastrointestinal tract, and that releases air into the abdomen. Okay, so how about all these answer choices? Let's start with mesenteric ischemia. That causes severe abdominal pain out of proportion to the exam, but no pneumoperitoneum. So this is going to hurt, ouchie, ouchie, but that is not going to explain the symptoms. Diverticulitis with perforation. So they do have acute diverticulitis that's complicated by perforation. That's evidenced by the colonic wall thickening and the pneumoperitoneum. And the clinical signs also indicate this. The peritonitis, the fever, guarding, rebound, all of that supports this. The other answers don't match that intraperitoneal symptom profile. Crohn's disease. That's a chronic diarrhea, weight loss, and skip lesion condition. You have the fistulas as well. It's not going to be acute perforation with free air. So that's not what Crohn's disease is. Endometriosis, definitely different. That's a cyclic pelvic pain with menses, not acute peritonitis or pneumoperitoneum. And acute cholecystitis, that'd be right upper quadrant pain and Murphy sign, and colonic wall would not be seen, right? What you do see is the right upper quadrant pain and Murphy sign and gallstones, but you don't see that pneumoperitoneum stuff. So anytime you see pneumoperitoneum, you should immediately be thinking of the perforation every single time. And so this time we got a woman who shows up, she's got all that abdominal pain, the fever, leukocytosis, guarding, and rebound. CT shows the free air, and all that leads us to think of a diverticulitis that has perforated. And diverticulitis starts with an obstruction in the diverticulum, leading to infection, inflammation, and then rupture. And the rupture spills the air and the bacteria into the peritoneum, and that causes a dramatic clinical picture that we're seeing in this patient. So the bottom line is diverticulitis with perforation is indicated by pneumoperitoneum, fever, leukocytosis, and abdominal tenderness. All right, I'm going to hide myself in front of the answer. A 32-year-old woman decides to take a hike on the Appalachian Trail, reaching an elevation of 4,000 meters above the sea. She has no significant past medical history, and she describes her physical condition as excellent. I would agree, just check out that image up there. After spending several hours at this altitude, she begins to experience shortness of breath and mild lightheadedness. Her vital signs include a blood pressure of 110/70, heart rate of 90 beats per minute, respiratory rate of 20 breaths per minute, and oxygen saturation of 88% in room air. Which of the following would most likely be increased in this woman as a direct physiological response to the decrease in atmospheric oxygen available at this altitude? Okay, so the answer is pulmonary vascular resistance. Okay, this is an awesome step one concept. So at 4,000 meters elevation, the atmospheric pressure of oxygen drops. There's just less oxygen up there. And that leads to alveolar hypoxia. And so the immediate response is going to be hyperventilation, right? You got to breathe, so increase your respiratory rate. The body's like, hey, have you tried that? Let's start breathing a bunch. And that improves oxygenation, but it also lowers the partial pressure of carbon dioxide. And carbon dioxide, you should think of that as pretty acidic. And so if you lower that, then it causes respiratory alkalosis. And so the key point is that systemic circulation generally vasodilates in response to hypoxia, but pulmonary arterioles constrict. And so that's the opposite response. It shunts the blood away from the poorly ventilated alveoli. And at a high altitude, however, the hypoxia is global. And so you have diffuse pulmonary vasoconstriction, which leads to elevated pulmonary arterial pressure and PVR. Okay, so the super big buzzwords here: high altitude means low PaO2, which means then hypoxic pulmonary vasoconstriction increases the PVR. And that tachypnea comes from the early acclimatization response. And so after days to weeks, the erythropoietin goes up, and that can cause polycythemia. And no, polycythemia does not refer to my junior year at Harvard where everybody started getting interested in political science. It refers to the abnormally high number of red blood cells in the blood. It can be primary or it can be secondary, and secondary is usually associated with the lung or heart disease or living at a high altitude. So then we get elevated 2,3 BPG, you get a right-shifted hemoglobin curve, and it's easier for the O2 to unload, and you can have chronic hypoxia, and there's a risk of pulmonary hypertension. It goes hand in hand with right ventricular hypertrophy or cor pulmonale. So the bottom line is at high altitude, decreased oxygen availability increases cardiac output to enhance oxygen delivery to the tissues. Our answer is D, pulmonary vascular resistance. If you found this helpful, please like and subscribe. In our next question, we have a 68-year-old man presenting to the emergency department with progressive worsening fatigue and exertional dyspnea over the past few months. On exam, he has a blood pressure of 135/80. His heart rate is 88 beats per minute and respiratory rate is 18 per minute. Auscultation reveals a loud S4 heart sound and a harsh mid-systolic murmur best heard at the right second intercostal space radiating to the carotids. An echocardiogram shows left ventricular hypertrophy with marked valvular calcification. The physician explains the patient's condition has placed increased demands on his heart. Which of the following sets of changes in the patient's left ventricular physiology is most likely? All right, so they've told us with the labs that this person has aortic stenosis that causes the pressure overload and the increased work. Right? You have to pump harder, don't you? If you have to pump harder, then the oxygen demand goes up. There's hypertrophied myocardium, that we know that from the S4 sound. And there's also increased wall tension. We know that because of the high left ventricle pressure and increased adenosine, which is a marker for ischemia ATP breakdown. And so our answer is increased oxygen consumption, decreased wall tension, and increased adenosine. So in aortic stenosis, the left ventricle can generate pressure over 200 milliliters of mercury just to push the blood out. That's super brutal, right? And so we have a harsh systolic murmur that radiates to the carotids, plus concentric hypertrophy, and all that tells us that it's aortic stenosis. And so the heart now has to do a whole bunch of work to go against that tight little valve. And so the work goes up, oxygen consumption also climbs because the thickened heart rate or the heart muscle needs more fuel, right? It's like a bad marriage. If somebody's constraining, somebody's just being a horrible person, then it takes a lot of work to make it work. It takes a lot of oxygen consumption to make a bunch of blood go through a tiny little valve. And that is the reason why our answer is C. The key takeaway is in aortic stenosis, left ventricular workload increases, leading to an increased stroke work and myocardial oxygen consumption. Here are the clues as to why it's aortic stenosis. The 68-year-old man, you get the calcific aortic stenosis there. Fatigue, dyspnea, signs of left ventricular outflow obstruction, and the loud S4 tells you that it's hypertrophied left ventricle, not dilated. And this, the harsh mid-systolic murmur at the right second intercostal space, tells you for sure that this is aortic stenosis. And so the tension goes down. In our next question, we have a 70-year-old man with progressive sensory neural hearing loss and is evaluated for possible interventions. He has struggled with understanding speech in noisy environments and has limited success with traditional hearing aids. After considering his options, he undergoes a procedure to improve his hearing. This procedure involves the direct stimulation of which of the following components of the auditory system? Okay, so sensory neural hearing loss, that's due to the dysfunction of the cochlea, the hair cells, or the auditory nerves. Hearing aids just amplify the sound, but it relies on the functioning hair cells. And so if you have enhanced sensory neural hearing loss, then the hair cells are just too damaged, right? You can't convert mechanical sounds into neural impulses if you don't have the hairs to sense those impulses. And so cochlear implants will solve this, though, by converting the sound into an electrical signal. And then they directly activate the spiral ganglion neurons. Those are the first order neurons of the auditory pathway that form the cochlear nerve. And that restores the perception of sound and speech comprehension in noisy environments in somebody who has sensory neural hearing loss. Why? Because sensory neural hearing loss is a problem with the inner ear or the nerve. And you have limited success because of what I described with hearing aids, right? Because you have damage to the hair cells. It's not just an amplification issue completely. And so you have to have a procedure that improves the hearing via direct stimulation through a cochlear implant on the spiral ganglion neurons, which is the site that are stimulated by the implant. And so our answer is C. Conductive hearing loss is improved just by traditional hearing aids, not implants. And the spiral ganglion nerves transmits to the cochlear nuclei in the superior olive, the inferior colliculus, and then the medial geniculate nucleus, and then the auditory cortex. And so the normal way that sound works is it's in the environment as a wave, and then it hits your tympanic membrane, and then you get the basilar membrane vibration and the hair cell transduction, which feeds into the spiral ganglion neurons and then to the brain. In sensory neural loss, you have damaged hair cells, and so you have the spiral ganglion neurons that are not stimulated. And a cochlear implant bypasses the hair cells and stimulates directly the spiral ganglion neurons. Basilar is one of those words that we often don't explain as well. That's just the base of something. The bottom line is cochlear implants stimulate the spiral ganglion neurons to improve hearing in patients with sensory neural hearing loss. There's our guy. He's going to hear again thanks to you. Studying hard. In our next question, we have a 35-year-old woman with a history of persistent hypertension and facial acne evaluated for a new diuretic. She has been taking hydrochlorothiazide for 3 months, but her blood pressure remains elevated at 150/95. Holy cow. Lab tests show serum potassium level of 3.1. Given the patient's clinical picture for lab findings, a drug of which of the following mechanisms should be considered for her management? And we got some beautiful answer choices right here. All right, so the big thing in this patient is we have some uncontrolled hypertension. We got to take care of that. And also there's hypokalemia. On thiazide therapy indicates the need for a potassium-sparing diuretic. And that's what we have to look for when we're dealing with drugs that affect the kidney. And there are drugs like spironolactone not only prevent potassium loss, but they also help with her acne in this case via the anti-androgen effect. So spironolactone is a double whammy for this patient. Just say, hey, would you like something that not only prevents potassium loss, but also helps with acne? She's going to say, oh yeah. All right, so the mechanism of spironolactone, you have to know. Which one is it? It is the blockade of the sodium channels, the ENaC, or aldosterone receptors, in the distal nephron. And so the answer is going to be C, blockage of sodium channels in the distal nephron. All right, angiotensin II receptors in the distal, those would be not acting on the nephron channels at all. They act on the AT1 receptors, so not quite. Inhibits sodium and chloride reabsorption in the distal convoluted tubule. Well, that's exactly what thiazides already do, and she's failing this, right? So don't give her more of the thing that she's failing. That would be loop diuretics like furosemide that worsens potassium loss, and it's not helpful here. Okay, so thiazide diuretics like hydrochlorothiazide lower the blood pressure, but often they cause hypokalemia. That's a huge side effect of chlorothiazide, hypokalemia. And so that's already what the woman is on, and her potassium is all the way down to 3.1. On top of that, that's literally pie, but on top of that, she has facial acne, which hints at androgen excess. And so the best next step is potassium-sparing diuretic like spironolactone. And these drugs block the sodium channels in the distal nephron, and it reduces the potassium loss. And spironolactone also blocks androgen receptors to help her skin. And so loop diuretics would waste even more potassium. Don't do that. Thiazide, she's already on it, right? And then angiotensin receptor blockers are not diuretics, so what are you doing there? And then the calcium reabsorption changes don't even apply here. And so it's just going to be the blocking of the sodium channels on the distal nephron. The bottom line is consider an aldosterone antagonist for hypertension and hypokalemia in patients who are on thiazides, especially if she has acne, which for some reason I failed to do. So just imagine it's me and I have acne. Oh my gosh, give me some spironolactone. Hopefully you guys can continue to learn at my expense. That's what I'm here for. All right, here's the next practice question. A 72-year-old woman is evaluated in emergency department, progressive lower back pain and weakness over the past 6 weeks. She reports nausea, constipation, and polydipsia. Her medical history includes type 2 diabetes untreated for 10 years. Physical examination reveals a frail appearing woman with mild lower thoracic spine tenderness. Lab studies show all of these things. Radiographs show multiple lytic lesions in the vertebrae. Bone marrow biopsy is pending, and after initiation of a rehydration and a loop diuretic to treat her hypercalcemia, which of the following classes of medication should be administered to address the underlying pathophysiology contributed in her condition? By the way, I make tons of awesome pieces of software that help you study for step 1, so visit the Chrome store to check that out. For instance, here's one. If you didn't know what potassium was related to, you can actually just search it on Sketchy. If you want that extension and many others, visit the store. And if you just want to help me out, then like and subscribe. But I digress. So, what should be administered to address the underlying pathophys contributing to our condition? All right, sorry I kind of derailed us there, but essentially the high yield facts here is that there are a couple of things which cause lytic bone lesions and hypercalcemia, anemia, and bone pain. And one of the biggest ones you should think of is multiple myeloma. And the best long-term pharmacologic management of hypercalcemia of malignancy is a bisphosphonate. It inhibits the osteoclast activity. And I want to tell you guys that on test day, if you're sitting there and you see a lytic lesion, then you should think plasma cell myeloma until you're proven otherwise. Especially if they have hypercalcemia and low phosphorus. Well, that's due to the bone breakdown from the osteoclast activation. And the symptoms would be nausea, constipation, polydipsia, weakness, and hypercalcemia classic presentation. And so the immediate therapy is IV fluids and loop diuretics. That's the first line to lower the calcium. And the definitive therapy is bisphosphonates that bind hydroxyapatite and induce osteoclast apoptosis and reduce the bone reabsorption. So the buzzwords are the lytic bone lesions, myeloma, right? Back pain, hypercalcemia, anemia. That's the CRAB criteria. Rehydration and loop diuretics already given. And so now we need definitive anti-resorptive drug. And the answer is bisphosphonates. Okay, so let's give her a bisphosphonate. The answer is D. The associations are multiple myeloma. And what to know about multiple myeloma, just really, really quickly, increased IL-6 and also that RINK-L activation, which increased the osteoclast activity. And so bisphosphonates inhibit osteoclast-mediated bone resorption. And by the way, resorption literally just means the process by which something is reabsorbed. So that's cool. But calcitonin is a short-term effect and it's not sustained. And corticosteroids are useful in lymphomas or granulomatous diseases, hypercalcemia, but not myeloma per se. And calcimimetics treat secondary hyperparathyroidism, not cancer hypercalcemia, and thiazides worsen hypercalcemia. So that's a really, really bad choice. So really the pathophysiology here is you have a malignant plasma cell that secretes cytokines, so IL-6 and RINK-L, and that makes the osteoclast activity go up, and then there's bone resorption, and then there's hypercalcemia and lytic lesions. And so bisphosphonates block the osteoclast function, and that reduces the bone breakdown and stabilizes the skeletal disease. And so the key features are bone pain, lytic lesions, multiple myeloma, hypercalcemia, nausea, constipation, weakness, polyuria, and bisphosphonates are the mainstay for malignant bone disease. You want to turn those off, look into the bisphosphonates. Okay, I can't tell if Giardia is like the most cute or the most terrifying parasitic organism. Maybe you guys can let me know in the comments. But that's my best attempt at drawing it. Here we have a 30-year-old woman, visits her PCP, recurrent episodes of watery diarrhea, abdominal cramps, and bloating. She did a humanitarian mission where the sanitary conditions were poor and she kept drinking out of the river. And she appears dehydrated with dry mucous membranes and has lost 6 kilograms since her last visit 3 months ago. Stool exam shows motile trophozoites with distinctive falling leaf motility patterns, and they look like a little pear, like I've drawn there. What is the pharmacotherapy of this condition? What's the mechanism of action of it? Okay, so this is metronidazole, because this is Giardia. Oh, that was off key. Giardia. That was still off key. I don't know. I can't sing. Giardia is the formation of the destructive free radicals. That's how it works. And so up to 30% of multiple myeloma patients present with hypercalcemia due to bone breakdown. And you think that's a high figure? Well, 20 to 30% of developing countries have Giardia prevalence due to their contaminated water and poor sanitation. And the attack rate after exposure is like 7% for campers and drinkers of untreated stream water. I've done it before. I don't know why I did it. I was young. I was in Boy Scout camp and they dared me to. But Giardia lambdia is the most common intestinal protozoan infection in the United States with a prevalence of 2 to 5% in healthy adults and up to 30% in developing regions. Crazy, right? What about inhibition of ergosterol synthesis? Well, that's azoles, right? That's for fungi, so no thank you. How about disrupted proton gradient through ATP synthase? Well, that's atovaquone. That's for malaria, babesia. How about competitive inhibition of dihydropterate synthesis? Well, that's like sulfonamides, bacteriofolate synthesis stuff. So that init chief binding to beta-tubulin, preventing polymerization. That's like albendazole, right? Those are for nematodes and helminths. So that's different here. You treat this Giardia with metronidazole, which becomes reduced in anaerobic organisms, and it produces cytotoxic free radicals that damage DNA and other critical molecules. That's why it works on the protozoa like Giardia. All right, in this question, we have a 65-year-old man who was brought to his primary care physician by his wife because she is concerned about his memory. Over the past several months, he has difficulty remembering recent events and conversations. He recalls events from distant past, but neuroimaging reveals a bilateral hippocampal atrophy. Which of the following cognitive abilities in this patient is he most likely to struggle with? So I've kind of drawn this dude's brain right here, and there are the lesion points. Always, this is the right side, this is the left side. All right, so that's my beautiful drawing. What is he going to struggle with? Okay, they kind of gave this away in the question sim, but before we answer this question, I want to talk about the pathophysiology so that we can understand why without having to memorize it. The hippocampus consolidates new episodic memories. And I like to think of this because I like Krapopolis, the TV show, and Hippocampus is like one of the people there, and he always consolidates new episode memories, right? It's like an episode. Also, atrophy will lead to the failure to encode the recent experiences. That's called Anterograde amnesia, and older memories are stored where? In the cortex. They remain preserved until later stages. So the hippocampus is the memory consolidation, and the loss of recent memory occurs first. Alzheimer progresses, then the language and the visuospatial defects, right? So our answer is going to be the remembering of recent appointments, not the old stuff. It's the forming of the new memories. So the bottom line is bilateral hippocampal atrophy indicates difficulty with recent memory, making remembering recent appointments the most effective cognitive ability. All right, folks, this is our last question of this set. A 29-year-old woman presenting to the emergency department complaining of persistent fatigue, lack of appetite, and difficulty sleeping for the past 2 months. She mentions feeling frequently overwhelmed and describes a low mood. She recently delivered a healthy baby girl 8 weeks ago, and the patient also has experienced moments where she feels disconnected from her baby and questions her ability to be a competent mother. She reveals that she has little interest in seeing friends and participating in activities, signs of depression, and her partner has been traveling over, which adds to her stress. And she denies alcohol and drugs. On examination, there's no remarkable findings. Which of the following steps is most appropriate in managing this patient? Should we suggest the patient enroll in a support group? Yeah, that's helpful later. But what they're really trying to get at here is this is like a safety check, essentially. So it's not quite enough. We need to do this expeditiously. What about initiate a discussion regarding her relationship dynamics with her partner? No, that's silly goose. Inquire about any thoughts and feelings of wanting to harm herself or her baby. Yes, infanticide, self-harm, very important. Assure her that such feelings are common and will resolve in time. No, our job is to assure when we have evidence to do so. But here, this is wrong, right? This is not just baby blues. This is actually a safety check, very important that we expeditiously inquire. Recommends an increased physical activity to boost her mood. That may help mildly with the depression, but it's not first line in a suspected postpartum depression. So before you think about support groups or medications, you have to do a safety screen. Point blank, just ask, do you have thoughts? That determines how urgent the intervention is. All right, so the baby blues, that's super common. It's self-limited mood disturbances, less than 2 weeks. But then postpartum depression is greater than 2 weeks, major depressive features, and it impairs the bonding and the function. And the first step in management is screening for this kind of stuff. And if she responds yes to question C, then emergency psychiatric referral or hospitalization is needed. And if no, outpatient treatment for psychotherapy and SSRIs, like sertraline, would be preferred if she's breastfeeding, for instance. There's the bottom line for postpartum women. Guys, you did it. Good job. Look at that. You did it. This is my message for you. You're going to pass. One thing that's proven to help is clicking the subscribe button. Just kidding, it's not proven to help, but actually I take that back. You know how many people have sent me saying they've passed 4 students recently? I love getting comments all the time like, hey, I just passed my exam. That's the whole reason that I'm doing this. So please be sure to like and subscribe. Let me know what I should cover next. Thanks so much for the 1,000 subscribers. Let's just keep taking this higher and make sure that you pat yourselves in the back. Wake up every day and say something amazing, something wonderful is going to happen to me today, and it will. The parking spots will open up for you. You'll notice the little things. Life is meant to be enjoyed. You can make it fun. Be kind to people. Be giving. Take it easy on yourself and tell yourself that something wonderful will happen every single day, and I tell you it will. All right, folks, you got this. We'll see you guys in the next video and in the community posts. Have a good one.